providing palliative care in non-cancer patients. So we will hear more about this from Rajagopal sir, who actually pioneered this in Kerala. And it's over to you, sir.
Sunil, thank you very much. And hello, everybody. Raju, right at the moment, I cannot see the audience. Do I understand correctly? This is the same group for whom I gave the introduction to palliative care and introduction to pain?
Yes, sir. And you have taken session of medical ethics and difficult pain also to them.
So, hello, everybody. Old friends, good to be with you. I came in 3 minutes late. My apologies for that. Please bear with me. Uh, so, as Sunil said, one of our responsibilities ethically is equitable care, equity in care, not equal but equitable. In the sense, depending on a need, our care has to be given to anyone who needs it. In our introduction, as we said, the indication is serious health-related suffering. The suffering of a person with advanced COPD, the suffering of a person with dementia, the suffering of a person, especially when they have hallucinations, the suffering of a person with amyotrophic lateral sclerosis, etc., can be much worse than with cancer. And actually, yesterday I was reading a blog by Dr. Richard Smith. Anybody who is interested, just Google for this. Richard Smith blogs. Dr. Richard Smith was the former editor of British Medical Journal, and he argues that death with cancer is so much kinder than many other deaths. It may sound revolutionary, but you will see that there's a lot of sense behind what he says. So, Sunil already pointed this lack of equity. We will have to accept that if an institution is dedicated to cancer, a cancer hospital, we can't expect them to look at palliative care for people with COPD. So let us remember that side also. There is that side to it. All that we are saying is, when it is not a healthcare service specifically dedicated to one particular disease, then we have to make our service available more broadly. An institution that is not dedicated to cancer, seeing only patients with cancer, is what I would say is inequitable. Raju?
Yes, sir.
May I share my screen?
Yes, sir, you can.
Okay, thank you. So in 30 participants, how many of you are able to think about your own death? I may have asked this question once before. Those who are able to think about your own death, if I ask you, would you like a sudden death or a slow, drawn out process of serious illness, stretching out into quite some time, and then eventually culminating in death? I have got a few chat responses. More people would like a sudden death, and Dr. Savitri goes one step further. She doesn't even want to know what's happening. If she wants to quietly die during sleep. X for one person. Every other response, no, two responses are different. Otherwise, it's all everybody's sudden death. One person, Dr. Jueria Rimi would like a slow drawn out process. Dr. Jueria, is it that you would like to live longer, or is it that you want your family to have a time, that period of time to get used to it? Juan Santiago also wants a slow one. Why? Yes, please speak up.
Sir, I would want a slow one in which my family members and also I am, I can finish up so many businesses of life, some loose ends and all. And my family can also be prepared mentally. I feel even I can, be finish off everything and be prepared for, just to make them prepared and for myself to be prepared.
Thank you. Thank you. Absolutely. I mean, that's the crux of it. Dr. Steve also would like to know before I die, but that can be a short time also. So here's the thing. As was mentioned, a death, quiet death during sleep, not being aware, is very pleasant for the person who goes. And Priya summarizes it all. Sudden death is shocking for our relatives, but a boon to oneself. That is, our suffering will be minimal. The family will find it very, very hard, and that's one of the hardest things in death from COVID-19. So thank you for your participation and your various answers, which helped me a lot in taking this discussion forward. Raju, can you please go to the next slide? So this, unfortunately, for those who want a sudden death, I must tell you, happens only in about 10% of people. At the most 15. 85 to 90% of us will go through a slow process of dying. Let us accept the reality. This is not something that we can argue about and bargain with. This is the way it is. Next slide, Raju. In something like cancer, one of the reasons why Dr. Richard Smith would rather die of cancer than something else is that the process is reasonably fast. Okay, you live with the disease, there's a chemotherapy, improvement, maybe there is a worsening, but in 2 or 3 of those peakings, you deteriorate and die. Now, 1 or 2 people said they want this time to prepare. Finish unfinished business. Write a will. Talk to the friends. Maybe your friend was closest to you in medical school, to whom you have not talked in the last 15 years. Maybe you will pick up the phone and give that person a call. These are unfinished businesses. Going slightly outside the topic, everybody here knows that everybody will die someday. Each one of us. You also know that sometimes the 10% that can be sudden, often unexpected. So maybe one preparation for not only for death, for life, is to finish unfinished business. You haven't written a will. Why? You are only 29. No age is too young. Write that will. Prepare your advance directive. If you have not in the last 2 months told your spouse that you love him or her, go ahead and say that. Hug your children more often. Pick up that phone and call your old friends. These are preparations for life. They are preparations for death also. But awareness of the possibility of death allows us to prepare for a healthier life, as the Bhutanese people know. You think about, remember that you are mortal, and that helps you to live better. Okay. Unlike in cancer, in most other non-cancer diseases, Raju, next one, please. There is often a longer drawn-out process, slow decline, periodic crisis, often you ending up in intensive care unit, sometimes gradually worsening the situation, longer stay in ICU, maybe invasive ventilation, coming back home in a more morbid state, quickly to return to the hospital and die a painful death. This is common. This is the reason why Sunil in the beginning said, if we concentrate only on cancer, we are going to leave behind a lot of people in suffering. Next, please, Raju. Let us take specifically the case of cancer and pain. In cancer, 75% of people have pain at some time or other. And two-thirds of them have moderate to severe pain. And sometimes it can be excruciating. In non-cancer conditions, there may still be pain. Contrary to what you believe, many respiratory illnesses are associated with pain. Many neurological chronic diseases are associated with pain. And here, the pain is not for 3 months or 1.5 years. The pain is maybe for 20 or 30 years. So, when we give treatment for pain, we have to remember this possibility. When long-term pain management is possible, we will try to avoid particularly damaging medicines. If you are using non-steroidal anti-inflammatory medicines, you will give them, if at all possible, in a time-bound fashion. I accept that in some cases of osteoarthritis or rheumatoid arthritis, reasonable quality of life cannot be achieved without NSAIDs. There you will continue even over the long term taking the precautions. But as far as possible, you will use as safe medicines as possible. Again, there is some evidence that long-term administration of opioids increases the chance of addiction in people with a genetic predisposition. Therefore, that also is one thing to remember. We have to remember that our aim in pain management in non-cancer conditions is not only pain relief, but also keeping the patient functional, allowing rehabilitation. So here we have to plan for the longer term. Raju, next one. We will also plan treatment to reduce hospitalizations. The remaining life should be lived as comfortably in the home setting as possible. We will always make advanced care planning. One of my colleagues was in ICU, a few years older than I with COPD, was in intensive care unit for about 2 weeks a few months back. When she returned home, I asked her, I think it will be good to talk about any such event happening again. She asked, why do you say any such event? This has happened already 4 times. So we talked about how invasive she would like the treatment to be. And at the end of this, we decided on a certain course of action. She wanted a copy of a sample copy of advanced directive or living will. I gave it to her. If there is a cessation of heart action, do you want to be resuscitated? Better put it in writing, but more importantly, discuss it with the family. And always plan for unexpected events. One thing that I would make a point of telling these patients is, if at night you have another convulsion or you have breathlessness again, let us plan what exactly you will do. Okay, have the ambulance number ready. Decide whether you want, where you want to go, to your regular hospital, to the palliative care center. Plan it in advance. Raju, next please. So as I said, because it is long term, it may not be a good idea to give opioids for the long term. Opioids should not be first line medicines as internationally approved in non-cancer pain. That doesn't mean that it can never be used. When needed, they should be used, but we should recognize the drawbacks, that's all. Raju, next one, please. Specifically, the British Pain Society's recommendation that the decision to start I'll let you read this. Please read this. The patient must know that this medicine has, in the long term, a potential for addiction. They should know what would be the consequence, what would be the manifestations. If you need increasing doses, you must consult us. You cannot increase the dose by yourself, etc., etc. Who wants to get addicted? Patients don't want to. Once we have explained the possibility, they'll be cooperative. Next, please. So to repeat, this is the Choosing Wisely program of American Society of Anesthesiologists. Choosing Wisely is done by other organizations also. Don't prescribe opioid analgesics as first-line therapy to treat chronic non-cancer pain. Next, please. Don't prescribe opioid analgesics as long-term therapy in chronic non-cancer pain until the risks are considered and discussed with the patient. What I mentioned already. Next. If you use non-cancer in non-cancer pains like rheumatoid arthritis, etc., if you use NSAIDs, routinely use gastroprophylaxis. We have already talked about it in another session, not me, somebody else, that today naproxen and ibuprofen are considered to be the safest for long-term administration. Diclofenac should not be given over the long term. COX-2 selective drugs should be used, if at all, only for the short term. And these are important for any patient, but particularly remember them if you are using them in non-cancer pain. Raju, next one. That was about pain. Now we'll come back to the issue of dying. In old age, dying is a protracted process. Often, it's 90%. So there are difficult decisions that are needed at many points in life. Listen, I'm talking about myself. These are things that I have thought about. These are things that I have discussed with my family. And I know that this is going to be not tough. It is not going to be easy. I might as well accept it. I very much count on Sunil to make sure that he will make me as comfortable as possible when my time comes. But I have to make my own preparations too. Next, please. The decline will be slow. Nobody will be able to tell me how long I will last. I may have multiple comorbidities. Gradually, I am likely to lose control over my own body, my own mind. Everybody usually says, I don't want to be independent. I don't want to be dependent on anybody. But I have to become dependent on somebody at some point of my time. Unless I am lucky to fall in the first 10%, I will be dependent on somebody. And I let mentally accept that. There may be heavy burden of symptoms. And I also have to remember that my wife is also elderly. My children are living elsewhere in the world. And my care needs may be considerable. And if I expect my wife to do everything for me, that may not be achievable. I may have to look for other sources, which is why all of you training in palliative care are going to be very important for me. Next, please. I may have multiple comorbidities, but the commonest ways in which that could possibly affect me could be a cardiac failure, a stroke, or a myocardial infarction. Or I already have some COPD, and that could get worse. And if I am really unlucky, I could have something horrible. All of them in the third category are things that I am scared of. I'm not afraid of dying. I'm not afraid of cancer. I'm not afraid of the others. But I still feel afraid of getting dementia or Parkinson's, advanced or ALS. Or frailty syndrome or senile debility is now considered one disease. It is included in the international classification of diseases. Again, mentally and physically, I may be having debility. So these are all common causes in which people die. Therefore, maybe not as part of the foundation course, but as part of your own preparation for future palliative care, you will and I need to inform ourselves a little bit about all of these processes so that we are able to help patients, so that we don't have to tell all of them, go to the neurologist, go to the endocrinologist. That is cruel at some point in the patient's life. Raju? When ejection fraction in a chronic cardiac disease falls below 20%, maybe it's very important to focus on quality of life more than before. This is the time when they find it difficult even to walk to the toilet. Emotionally and physically, helping the patient to cope by accepting a chair commode instead of the walk to the bathroom, maybe, or a wheelchair. Reducing hospitalizations by that preparation. Even if when you have maximized medication, you may still be having symptoms. And sometimes you will have to make a choice about whether to go in for a particular implanted device, a pacemaker maybe, or to accept whatever comes. It is a person's choice. We have to help them to make decisions, not making decisions for them. When I say all this, some of you would be thinking of your own relatives, your family members, who may be in some state which may be close to this, who may have already gone through this state and died. And for some of them, I could be raking of painful memories. I'm sorry if I am doing that, but I'll also point out, maybe talking about it is cathartic, helps you to cope with those thoughts and heal a little more. Next, please. And we were talking about cardiac diseases. Any one of those dips could be the patient's last. And especially discussion, Raju, next, discussions regarding how much care needs to be given has to be taken in advance. In dementia, people may not be able to walk, dress, or bathe. There could be incontinence. See, I'll let you read the rest of it. How much will you intervene? If the patient and family, no, the patient is at a certain stage unable to take decisions, if the family decides not to go for aggressive treatment, I will be lucky. Because at that stage, it is a horrendous infliction of suffering for me when I am not in control of my mind to put me on life support systems or on aggressive treatment. You should know that a patient with dementia is most comfortable in his own familiar environment. Taken out of that, they become afraid. They sometimes get agitated. Raju? If it is a COPD, for example, any interstitial lung disease, for example, at some stage, I could be getting dyspnea at rest. Initially, there may be a response to bronchodilators, then not. Functional ability will decrease. I will be easily fatigable. And unless we are planning, these trips to the emergency department will become more frequent. I will develop cardiac failure, and I will be at risk of developing hypoxemia. If I choose not to go to the emergency department, but to come to you, what treatment will you give me? Will you give me oxygen? Tell me first. I am going to try oxygen on you. If it makes you comfortable, we will continue it. Why not? I may choose to use oxygen at home. Next, please. Even, how about renal failure? Unfortunately, renal failure is too often associated with pain. And we have to remember that methadone and fentanyl could be the safest. If it is a patient who is going in for dialysis and you adjust the patient's morphine dose, not 4 hourly in somebody with renal failure, maybe 8 hourly, maybe 12 hourly, maybe once a day. But on the dialysis table, because morphine will be dialyzed out, they will get terrible pain. So one of these medicines may be better. Next, please. And that's not only for pain, it's also for breathlessness. Because in renal failure, often there could be respiratory failure. Next, please, Raju. The usual road actually in renal failure is not too bad. Death from renal failure for the majority of people is not a bad kind of death. You become sleepy, lethargic, comatose, and you die. I wouldn't mind that compared to the dementia. But it need not be like that. Next, please. The difficult road would be restless, confused, hallucinating, convulsions, and that could be a lot of suffering. So generalizing and saying that death in renal failure may not be too bad may be true for the majority, but for a significant minority, that may not be true. These symptoms we may have to treat symptomatically. That is, if you are not going the aggressive route of renal transplantation or dialysis. Continue. Next, please. So I'll stop there. I believe we have finished early enough for the discussions that can follow. Raju, I'm just moving out to get a drink of water.
Okay, thank you, sir. So I think we can ask questions as much as you want. We have 20 minutes. Okay. S- uh, so what are the resources for, sir, there is a question. Where could we find out the resources for palliative care in non-cancer illness?
In non-cancer illnesses or a specific illness? What's the question, Savitri?
Palliative care in non-cancer illness.
Uh, so let me find a resource, and I do have a book with a chapter on non-cancer illness, 2 chapters on non-cancer illness, but it is copyrighted book. It will not be correct to share it widely. So I'll have to look for another resources. Raju, as you are waiting, will you please write me a short message to give me a memo?
Yes, sir.
Thank you.
So can you share something about advanced directives in India? You told you gave a copy to one of your colleagues. How relevant, and how is it? Can you tell? You told you can do it right now. Can you tell? Can you share some of your knowledge?
Steve,
Yes, sir.
I already told you this. You are young people, yet I told you, any time is the right time. You don't have to be ill. See, if you are able to contemplate your own death, if you are able to accept your mortality, you will also accept that 10% of deaths occur suddenly, and many of them are due to accidents, natural calamities, etc. So prepare a will, preparing your advanced directives. In today's healthcare, when hospitals tend to intubate and ventilate everybody, all these preparations are done as early as possible. Now, maybe I told you this already. Did I do end of life care for you? Your batch?
No, sir. It is towards the end, sir.
Okay. Maybe in Bhutan, everybody is asked to think about every adult, not every elderly, about your own mortality 5 times a day. Remind yourself, you are a temporary occupant of this world. That realization helps you to live better, to live happier, but especially in the context in India, when reasonable artificial life support is being given to everybody, it's better to make the choices early. First answer, do it when you are healthy. Second answer, if you are as the palliative care physician, you are a patient, if you are having a good conversation about a person with a curable cancer, your conversation, if the communication is going the right way, your cancer has a very good chance of recovery. If we get the right treatment, every possibility is that you will be cured with the treatment that the hospital advises. Do you have any more questions?
So is it a legal some paper or something where you said you gave a copy to your colleague or something like that? What is it, sir? I'm not aware. Like
okay, in a moment I will come to that. So that conversation, if possible, will also take me to ask, but if the cure is not possible, have you thought about, like usually they will bring it up when I say that you have a very good chance of cure. But if they say maybe suppose I don't get cured, we will make sure that you're as comfortable as possible, etc. That conversation would lead me to advance directive. Yes, Steve, there is a document. Steve, where are you from?
Sir, I am basically from Kerala, sir.
Okay. I just wanted to know whether you are an Indian, that's all, because the Medical Council of India, very many years back, created a document which was an advance directive only for people with vegetative state of mind, state of illness, vegetative state. But we have, Palliative India has modified that and made it applicable, made it suitable for anyone. We have it on our website. And Raju, please make a note of this also. We will send it across to all participants. The copy of Palliative India's advanced directive, which is a modification of Medical Council of India format.
Thank you, sir.
Dr. Sakshi was telling that she,
Yes.
yeah.
Sakshi, you want to unmute and tell us a little bit about your experience with your grandmother? How, and was she reasonably comfortable, or was she suffering a lot? I know that this can be very hard memory. I won't force you to talk. If you are a bit overcome, don't talk. It's okay.
Dr. Sakshi, can you unmute? Yes.
Yes, sir. So actually, she was a very independent woman. Like, she was very active throughout her life. But I think the first time when she got the attack, it was in 2000. And then I saw her completely bedded, like how we say the quality of life really decreased. But she had that will in her to keep going through her physiotherapy classes. So she was always at home. She was made comfortable. And my grandfather had passed away, and before this happened, so she was all alone. I felt, though we stayed in a joint family. Like, I belong to Gorakhpur, sir. It's a town in Uttar Pradesh, and we have a joint family. My father, my uncle, and the kids. All of us were together at that time. So initially, I felt she could still cope up. She had a lot of strength in her and a willpower that she kept doing physiotherapy. She was fine. She would still have her friends coming, would take keen interest in watching television or talking. Her memory was very, very sharp. She remembered which cupboard she had kept what. In fact, she started writing from her left hand because her right hand had no strength. But then the last 2-3 years, I really saw a drastic decrease in her health. And by the last 6 months, she really wanted to die. Like, when I last visited her in March, she told me that she had lost the will to live because she had slurring of speech and no one could understand what she was talking, and it worsened with years. So in the last 1 or 2 years, it had become, she used to become very irritable that no one could understand what she's saying. She used to try writing on the chalkboard, but her hand used to still tremble. So those little things really bothered her. Then again, we had a full-time nurse at home, but if the nurse went somewhere for a few minutes and she had to go to the washroom, so it really affected her. And then she fell down while going to the bathroom. She had a fracture, but she could not be operated because of her age and condition. So even though on a pain scale, I wouldn't say her pain was a lot, but all these were a lot of sufferings, which now in fact, I go back and question my mother that why wasn't morphine given, or could we have done this? Like, at the end of every class, I try to correlate with her a lot. So.
Thank you for sharing your painful story. It cannot have been easy for you. Inside, you must have been crying as you said this. And you did that for our benefit. So particularly, thank you. And you mentioned this. There must be others who have similar stories, who may not be able to share it the way you did. You were brave. And I was thinking of my own grandmother, how she wished to end her life. I mean, she didn't want to end her own life. She just wanted to die. And once she asked me whether I can give her euthanasia, uh, I could not, but I tried to give her the next best thing. That's give her love. Let her know that she is loved. Let her know that she matters. Give companionship as much as we could. Other things. Functionality above safety would be a rule. Unfortunately, she got a fracture. And I had this question put to me by a patient's son recently. My mother is 94. She has developed this fracture. The risk will be very high. I don't think it's right to operate on her. What I told him was, if you don't, what kind of a life will she have to live? The risk of surgery could result in death, but if not, it could be a miserable life. I think she deserves that opportunity. The only point is, let us make sure that she gets excellent pay post-operatively and gets mobilized as soon as and rehabilitated. So this is difficult decisions, but Sachi, thank you for sharing that story. How are we doing for time? We do have some more time. Anybody else wants to come in?
I would like
So yes. Sorry, Sunil.
I would like to share an experience. A patient
Yes.
who is presently admitted with us yesterday. So she's a 24-year-old female who is married, and she became pregnant. But then she had frequent breathlessness, cough. But when they investigated, they found that she has interstitial lung disease. So uh, she there was a medical termination of pregnancy because of her health condition and the medications that she has to take in, and she has been breathless for past 4 5 months, and she was unable to sleep for the past 4 5 months. She is on continuous oxygen, and this patient was referred to us by a pulmonologist. So she came here yesterday. We gave her 2.5 milligram of morphine yesterday, and she had relief of her symptoms, and for the first time in the last 3 4 months, she was able to sleep comfortably yesterday. And she's also saying that she's able to go to bathroom now. And she says she feels much comfortable. So I just want to tell you that patients with chronic illness, which is not curable, like interstitial lung disease, they are suffering a lot, and we can do something to help them. And I think when we optimize the dose of morphine, she will be more comfortable. Thank you.
Sunil, that was very important. Yeah. How many people in this group have read Atul Gawande's book, Being Mortal? As it curiously happened, it was borrowed by somebody from me and was returned and is sitting right by side. This is Atul Gawande's Being Mortal. It was in New York Times bestseller list for a long time and is still revered by people all over. Atul Gawande is a surgeon, and he is writing about being mortal. I think it's essential reading for all human beings. And he particularly talks about this conflict between safety and functionality.
There are
Yeah, I'll read that. The Geetika's question, most of the time towards the end of life is spent in panicking. How can we manage this terminal anxiety on the caretakers and patients' part so that it can be spent in a better way? How do you convince and empower? Geetika, the process of convincing and empowering has to start early. Unfortunately, it's not very easy because in our country, there are no GPs, no general practitioners. 3 different specialists give orders for each individual organ. And we, if we are acceptable to them, could be the coordinators. It's about, okay, let me try to answer the question. And I don't know if Raju, you will have to give me a warning if I end up repeating the same thing when we discuss end of life care. But you may have people like that in your own home, your grandmother, and or maybe a patient that you have time to spend with. Ask them to share their life story. Tell me the story of your life. Find out what is important to them. Some people want to go on. I want to live as long as possible because I do want my granddaughter to. I want to see my granddaughter married, and we should do everything to keep her alive, depending on how far she is willing to accept invasive treatment. It's not our choice, it's her choice. But the person may say, very well, just as my grandmother used to say, my life is complete. I've seen you all grow up. I've seen even your children grow up, 4th generation. And now, what's the point in continuing like this? I am ready to go. And we have to be there for them, not forcing antibiotics and this and that on them, but in this business of making them comfortable. So this process, unfortunately, will succeed only if the family is with you. If the family is in conflict, and if the family does not cooperate, none of this will be possible. That's the reality. So you cannot always win. What we will also tell that grandmother is, look, give me permission to talk to your children about your wishes. Let's have an open discussion. That would be the ideal thing to do. Geetika and Shubhra, Raina. Oh, relatives insist for aggressive treatment. Oh, do we have time, Sunil? 3 minutes more. Good. Maybe this was already discussed in communication session. This is a frequent thing, isn't it? Very often. I know I am ready to go if I have to, but my children love me so much that they want me to live. Most importantly, don't get into conflict with the family. Recognize that the family is usually saying that out of love for the patient. Sit down with the family member. Unfortunately, one will be in USA and only will be in Dubai. That's always a problem. But if we can get them together, sit down and talk to them. This is what I'll start with. I see that you love your mothers very much. It is heartwarming to see the extent of love that you have for her. You are acknowledging the truth. And one of them will say, yes, yes, my mother was very special. She never cared for herself. She always lived for us. She is full of love. And I will say, but maybe she is also lucky that she has loving children like you. You want to do the best for her, and I want to do the best for her. Let us talk about what is best for her. Tell me, what kind of a person is your mother? Was she active? Do you think she would want to just exist dependent on anybody, everybody? Or would she want to be as active as possible? Depending on that, we'll have to plan the treatment. This conversation may not finish in one session. It may be several, but those conversations are very important. Priya says the love that we give is what matters the most. The love that we give and the opportunity for them to give you the love. That will be very gratifying for them. Also, we try to make them feel that they are important for us. So in spite of terminal stage CA stomach, he is with us happily. That was where she was talking about her father. Priya, maybe one step further you can go is to ask your father, Dad, tell me about your childhood. Tell me the story of your life. And you then will hear things that you have never known about his childhood, about how he grew up, about his principles. And then at the end of the conversation, you may actually find that you know your dad better than you ever did before. And if you are non-judgmental, then he may actually say what he really feels inside, because sometimes they pretend to be happy to make you happy. A loving dad. It's important to get out what he really feels inside. Best wishes, Priya. Most happy if you want to write to me. Raju will give you my email ID. And Neelima, absolutely. Paul Kalanithi's Breath Becomes Air. When Breath Becomes Air is another book to read about the surgeon Dr. Paul Kalanithi's death just a few years back, 4 or 5 years back, from cancer over a year. And Lucy Kalanithi is still an advocate of compassionate care, his wife. Yes, Priya, thank you very much for sharing that story. I have exceeded my time as usual. Thank you, Sunil and Raju, for facilitating. I am now happy to sit back and listen to you all. I'll just take a half a minute break, but I'll be back with you. Please proceed. Don't wait for me.
Okay, thank you, sir. I think we will move on to patient story. So it will be presented by Dr. Savitri. Dr. Savitri.
Good afternoon, all. Am I audible?
Yes, you are.
Yes. Sorry, I won't be able to switch on my video because of data constraints. My name is Savitri, and I'm working in this secondary care hospital in Chhattisgarh. I just freshly passed out of MBBS this year, and it's been just 1.5 months since I started working. So here we do not treat cancer patients. The moment we diagnose cancer, we refer them to a higher center, which is possibly a designated cancer center. We only treat non-cancer illness, and because of the socio-economic status of the people around here, the cultural factors, many of the illnesses present to us in their very complicated state, where many times we have very little left to do. And even during my internship and even now, I see that we discharge dozens of patients to home, saying that there is not much we can do for you here. And they also say, please discharge the patient because we do not have any more money to pay you. So many times they go back home and we do not know what happens to them after that. How is the quality of life? What are they doing there? So this case is also, the case I'm about to present is also a similar person's case. So this is the case of a 52-year-old woman who came to us, and she was diagnosed with quadriplegia following cervical cord injury due to a road traffic accident. So she presented to us in the emergency department with complaints of inability to move both upper and lower limbs since 15 days following a road traffic accident. And she also had loss of appetite since 4 to 5 days and generalized body pain. She also had a lacerated wound on her forehead, which was also from the accident, and it was painful and it required periodic dressing. The patient and her son, they were traveling on a two-wheeler by road, and they met with an accident, and she suffered a head injury to her forehead as well as to back of her neck, and also some minor abrasions on her arms. So she was taken to a nearby private hospital for first aid, and they did an MRI and imaging, and it showed that the cervical spine had contusion and edema, and disc protrusion at the level of C3, C4, and C5, C6 levels. So immediately a spinal decompression surgery was performed. This was on 30th August, around 15 days back, involving C3, C4 laminectomy and lateral mass fixation. The patient has, when the patient presented to the hospital, to this day, there has not been any improvement in her status. She's not able to move any of her limbs, but her sensations are intact, with sensations reduced on the right side as compared to the left. So a CNS examination was done, which is in the next slide. So the patient is conscious, cooperative, oriented to time, place, and person. Cranial nerve functions are normal. Motor examination, the power is 0 in all the muscle groups of bilateral upper and lower limbs. In sensory examination, pain and crude touch sensations are present. Reflexes are exaggerated, indicating an motor neuron type of paralysis. As far as her bladder and bowel movements are concerned, she's able, a catheter is in situ, she's able to sense the presence of a catheter. She's also able to sense, feel the urge to defecate. So treatment and significant investigation. So her story is that she was actually taken to a private hospital, and there a surgery was performed on her. And then after some days of investigation, she was discharged. But then her family did not know what to do with her, so they brought her to our hospital basically, because she was not able to continue nursing care. So here she had come more for nursing care because she had also developed some bed sores on her back. So her electrolytes, blood sugar, and complete blood count were done and were within normal limits. She's currently being treated with IV dexamethasone 2 ml every 12 hours, IV fluids, amoxiclav tablets 625 milligram BD, and ibuprofen 400 milligram 8 RV. A Foley's catheter has been put in, and her temperature and vitals are being monitored. The wound on her forehead is being dressed regularly. As far as the psychosocial aspects are concerned, her family consists of her husband, her 28-year-old son, his wife and 3-year-old child, and also 2 daughters who are married. Her son also suffered a fracture of right leg in the same accident, and he's currently at bed rest at home. The family is they are dependent on agriculture for their income, and they had 3 acres of land. But then the surgery and the treatment in private hospital cost them approximately 1 acre. And that is one of their major concern regarding financial expenses. Her daughter-in-law and son, they are separated since the past 1 or 2 years. And because of that, she is the only woman in the family, in the sense that most of the household chores are done by her. So she and her husband are obviously worried about her prognosis. Will she ever be able to walk? Will she be able to sit? Will she be able to at least do her own chores? And she herself wishes that she'll be able to do at least the chores within her home, so that her husband and son can go outside and work and on. She, as far as her own mental status is concerned, she is obviously worried and depressed about what is happening currently, but she's grateful for her husband who is being taken care of her very well. She also feels guilty about some of her earlier behaviors towards him. I do not know the details of this incident, but she mentioned this while speaking. So my main concern regarding this patient is that her home is in a village which is at least 30 kilometers away from our secondary hospital. She does not have any good medical help nearby. So if this patient is discharged from our hospital, how to provide this patient with a low resource intensive palliative care at home, where there is absence of any trained health professionals, and which is also affordable for her as well as her family. So this is my main concern. So this is summaries of a 52-year-old woman with quadriplegia following cervical spinal cord injury, requiring long-term home-based palliative care. So my question is again the same. So how to provide this patient with a low resource intensive palliative care at home in absence of trained health professionals, which will be affordable and feasible for the family. Thank you very much.
Thank you, Dr. Savitri. So I'm sure many of you might have faced the same situation, and you have wondered what can we do in such situation. So any of you can have your thoughts on this. Anybody? Any comments?
Hello.
Yeah.
Can I share something?
Yeah.
When I was in Kerala last February, one thing that I I really admire is that they have this community palliative care that they train the family members, the community members, in order to deliver palliative care to those who are in need in the community. I
Okay.
think that is one of uh, way of providing patient care is to deliver is to train the family members and yeah the community members.
Okay. So where were you in Kerala?
I was in the Institute of Palliative Medicine. I trained for the fellowship in community palliative care.
At Calicut.
Yes, in Calicut.
Yeah. Okay. Yeah, that's true. In Kerala, there are many NGOs who are doing palliative care, and they take care of many patients, which also include non-cancer patients. So maybe 50 percentage of patients will have cancer, and rest 50 will be having non-cancer diseases. So many palliative care units. Uh, they have inpatient units, as well as there will be volunteers, so they will teach the family member how to take care of the patient. So that can be done, and with a very low cost, what can be done at home. And there are many aspects to this. So there would be physical problems that has to be addressed, psychological problems of the patient, social and financial problems, and maybe rehabilitation, vocational rehabilitation of the patient also. So all these are taken care of by either by the by palliative care units with the help of volunteers. So that is being done in many palliative care units in Kerala.
Once, do you think a similar movement is possible? Sorry, which country are you from?
I'm from the Philippines, sir.
Do you think any such engagement of the community is possible?
In our community, sir, in our
Yes,
country.
yes.
Yes, sir. Actually, I am about to start this program here. Actually, it was just halted because of the COVID pandemic, and we already engaged the stakeholders to start a community home care in the village I am with now. So, with the coming World Palliative Care this October, I think we are going to launch the project. However, there are limitations such as we are not allowed to do face-to-face consultation with the community members to avoid transmitting the virus. So we are looking for the possibility of telemedicine or televisits through video or virtual conferences or virtual consultations instead of the face-to-face visits.
Vanja, all success to you. Wish best wishes. That's a noble
Thank you,
task
sir.
to do. But of course,
Actually, sir, I was inspired by what I experienced in Kerala. That volunteerism is very high, and everybody wants to help each other, and the community was really capacitated to help in terms of palliative care, and that's
once,
thanks to the people of India.
no, I mean, let me express one word of dissent. It is not true that everybody wants to help everybody. That's not true. I have never seen a community anywhere in the world where some people are compassionate. They are there in Philippines,
Yeah.
they are there in Kerala. What only thing is, we should offer the compassionate people an opportunity to be able to help others.
Oh, yes, sir.
Uh, Sunil, do you want to tell them about when COVID struck, where there was lockdown and people found themselves without essential medicines? Do you want to tell them about what we did and a new set of volunteers, etc.? Raju, shall we stop the screen sharing so that we can see one another?
Okay, so when there was lockdown due to COVID-19, there was many difficulties for the patients as well as the healthcare workers. So we were unable to go out of the hospital, but even then we were doing the home visits at a minimal level, but there were more problems for the patient and family. They were unable to get medications or food. So we gave an advertisement for volunteers, and many have applied, and we asked them to we gave them a training virtually, and then they were asked what to do, what not to do, and these volunteers were helping us in distributing medicines, and they were also going to patients' houses for giving food kits, and so there are many people who is willing to help the others, but even during this difficult time where many people are sitting at home, they came forward and did this for the patients. um, uh, so what else?
No. I mean, like even in the most difficult time, we called for volunteers and we had more about 90 people. Our advertisement said we want people between the ages 20 and 40 with their own automobiles. A lot of people with two-wheelers and some with four-wheelers volunteered. They could not go for their own work. They volunteered. And so these people are there in any environment. So maybe it's finding them and empowering them.
Dr. Savitri, in this patient's case, I think we have to train the husband regarding how to clean and dress the wound, and maybe he might need some physiotherapy.
The second stage is the newly married.
So he might need some physiotherapy, which can also be done by the husband. Then the skin need to be taken care of. Maybe he might need a water bed or air bed. Uh, so he need to know what all has to be done for his wife. So this can be done when the patient is at the hospital, so that husband will learn more and he will be able to do things when they reach home. Um, from a psychological point of view, the patient and husband may have maybe worried about their future and will be sad. Maybe if we can give them a clear picture of what is going to happen in the future, even though we may not be able to give a clear answer, but we can give them some idea. And from now, because the husband has to go for job, probably the wife will be alone. So we also need to make some mechanism by which the patient will be taken care of by somebody, maybe the neighbor or by a volunteer if it is possible. And yeah, and maybe you can also give your nurses, or if possible one of the doctor's number, so that in emergency, or if they find, if they have any doubts, they can call you over the phone. And even telemedicine can be done nowadays. So this all can be done when the patient is at hospital, if you teach the husband. Okay, is there a protocol for community-based palliative care, a training manual for volunteers or something like that? Sir?
Yes, indeed, there is a, we do have a volunteers training program module. Raju, that's another thing to be shared. Our training module, including the must-learn point, learning outcomes for volunteers. There is a training manual also, but that's in the local language, more detailed. But this short document is, Dr. Savitri, something that we'll share with everybody.
Anybody want to ask anything or any comments?
Shubhra Raina asks, do we have rehabilitation centers in India like Western countries where people who need prolonged rehabilitation can stay? Shubhra, to start with, if we have centers like Western countries, they will be affordable only to a tiny minority. That's the reality, see? Everything is available for the filthy rich. Ordinary folks get nothing. So what we need, maybe if I may change your language slightly, rehabilitation centers adapted from Western models to suit our socio-cultural and economic realities. Indeed, our institution does have a halfway home, which is now closed because of the COVID season. But ordinarily, in our halfway home, we take in people who need, especially people who have paralysis, mostly people with spinal cord injuries, but also other diseases. So here they come and stay for anywhere from 2 weeks to 3 months. The center concentrates on physical rehabilitation. That means simple things like moving by oneself without somebody else's support from the bed to wheelchair, learned in 3 days. World expanded 7 times, making a cup of tea for themselves. Those who are interested, maybe doing a little more cooking. If the family members are going out for work, they don't have to eat a cold meal in the midday that is prepared at 4 o'clock in the morning. They can have a warm meal. Everybody is explored to see what their abilities are, what their strengths are. So some people learn to work on computers if they have enough language skills. We have 3 people making superb umbrellas, and we try to do a little bit to market them for them. So any vocational rehabilitation is also attempted, but also we screen them for depression or other psychological disorders. and treat them. So it's physical, psychological, social, and vocational rehabilitation. Yes, we have a few centers in Kerala, too few doing that kind of thing, but these are centers for the, not for the rich people. I'm sure there must be other centers for the rich, but very often those centers do not give holistic rehabilitation. Their rehabilitation is confined to physical rehabilitation, is unfortunately what happens in many places. Karpaga asks, okay, Sunil, this is a question that you have posed to the group, right? What is advanced directive?
No, sorry.
It's a participant, Sunil.
Dr. Mohitpal was asking, sir, please tell the name
Dr.
of...
Sunil. No, Sunil is asking, this question is, what is that? No, there's a...
No, sir, actually he was responding to my query about a blog spot that you had mentioned earlier in your presentation. Dr. Edward, I was missing out on that name to search on Google.
The blog I mentioned was yes, the blog that I mentioned was Richard Smith. Richard, R-I-C-H-A-R-D. R-I-C-H-A-R-D, Smith, Richard Smith. And his person.
Thank you so much.
Okay,
yes, thank you so much.
Karpaga asked a question. Karpaga's question is, why aren't hospice available in all towns of India like PHC? What is PHC? Primary health center. Oh, like primary health center, why aren't hospices available? Karpaga, hospices are expensive to run. A home visit program is not expensive. Outpatient clinics are not expensive. Hospices are expensive. Imagine if you have 15 patients, how many staff members will you need? How many shifts? Keeping the place, it is expensive. So we do need hospices, but they have to be, they cannot be hospices like St. Christopher's Hospice in London. We'll have to make them suitable. Unfortunately, there are more and more people left without carers, and our country makes no provision for them. This has to improve. Old age or retirement homes, friends from Sakshi recently came across a friend's mother. How are we doing for time? 4:26. So, who used to stay separately from her daughter in the same town, now wants to move to an old age house rather than her daughter on her own will. This is a person who does not want to be dependent on the daughter, and we'll have to respect that. What I'll do is I'll sit down and listen to her story. If it is a misunderstanding that causes that attitude, that may be okay, but this is very often the case. Look, in every household, it is not like the olden days when there is an extended family, somebody or other will care for the ill person. Now if I am ill, and if I am staying with a daughter or a son, it will depend on not only on that person, but also on the spouse. If that spouse is not cooperative, the son or daughter is helpless. These are realities. We'll have to accept that. So there are retirement homes. Unfortunately, most are like prisons. They give food, they keep their hours, everybody has to attend prayer at the appointed time, etc., etc. And unfortunately, if they get seriously ill, they still get sent to ICU units. So, who was it asked? Karpaga? No, it was Sakshi who was asked it. Sakshi, it's up to us to do this, Sakshi. Ideally, people should be staying in their homes, but it may not be possible. And a lot of elders are now living alone. And when they are sick, nobody sees the horror under which they live and die. So this is a social need, no doubt. And maybe if you show the way, Who knows, some social organization, maybe a Rotary Club or Lions Club, or more likely some local bodies may come forward to do this. But again, as I said, a residential home is expensive to run. Starting it is easier than running it.
Thank you, sir.
One more question in the chat.
In Indonesia, we have stopover house. Can you give a comment about the efficacy of the stopover for palliative patients? Edward, that term is not familiar to me. What is a stopover home? Is it a daycare center where the family can drop the person in the morning, go for work, come back and collect the person in the evening? Or is it that if just for a few days of respite care? What is a stopover home?
Excuse me, sir.
Yes, Edward.
This is Edward. A stopover house is a house that used when patient after discharge from the hospital, and but the patient need again to back to hospital to continue medication such as chemotherapy. So for a while to have near the hospital, he go to stop over, and if there anything happen, some urgency, the patient can go to hospital in a short time.
Yes, I see what you mean, Edward. We do have, I live in Trivandrum, and around the regional cancer center, there are 7 or 8 institutions like this, mostly charitable, but not all of them, where such people are taken in and cared for. Unfortunately, most do not include palliative care. They are just house people and give basics facilities, and a lot more of growth is required. I'm very glad that you have that in Indonesia. I hope those stopover homes will incorporate principles of palliative care. Sunil, I think time is up.
Okay. Let's wind up the session for today. So thank you, sir, for being with us today. And